The Frailty Seminar Series 2023 to 2024.
It's time to start. Welcome everyone to our Frailty Seminar Series organized by the Global Frailty Network. My name is Gustavo Duque. I'm the Kihon Chair in Geriatric Medicine at McGill University in Montreal, Canada. And on behalf of all our steering committee, members of the steering committee of the Global Frailty Network, we would like to welcome you to our last seminar of this season. It's my pleasure, and before I introduce the speaker, actually, I'm going to give you a couple of points that we want to update you on about our Frailty Network. I hope you have already visited our website. We have some information regarding the Frailty Network, how to join it, how to attend the seminars. And for those of you who missed previous seminars, please feel free to go to the website. Those videos are available there. As you know, we have fantastic speakers and very interesting topics. So all of you are welcome to join the network, to listen to the previous seminars, and also to send us some suggestions regarding topics that you are interested on, all of them related to frailty from bench to bedside and community. The other point that I want to highlight today, or we want to highlight today, is about the next year's schedule for our frailty seminars. The schedule is ready, and we are going to circulate it amongst all our members and networks soon. However, we can already confirm that our first seminar for the next season will be on September 13th. With our speaker would be Dr. Jeremy Walston from Johns Hopkins University, and he's going to talk about resilience in frailty. So with this, I would like now, I can go ahead and introduce our speaker, who is a very good friend and is a very well-respected authority, worldwide authority in this topic, Professor Hidenori Arai, who completed he's a geriatrician, and he completed his MD and also his PhD at Kyoto University in Japan. Professor Arai is a worldwide, as I mentioned, worldwide authority, and has published many papers, in more than 200 papers in the fields of sarcopenia, frailty, nutrition, resilience, and he has also conducted many clinical trials and cohorts in the fields of frailty, sarcopenia, and nutrition. So with this, I would like to welcome Professor Arai. Professor Arai provided us with a video, but he will be with us at the end of the session for our questions and answers. So please, everyone is encouraged to submit your questions or your comments using the questions and answer function in Zoom, and we will try to answer, or Professor Arai will try to answer once he joins our session today. So in the meantime, we're going to listen to Professor Arai's video and also to watch his presentation.
Hello, everyone. My name is Hidenori Arai. I'm president of the National Center for Geriatrics and Gerontology, Japan. I'm a geriatrician. I'm going to talk about community approach for frailty prevention, but considering that our goal is healthy aging, I'm going to talk about dementia prevention as well. There's no financial disclosures. Before going to my talk, I'd like to introduce our 6 national medical research centers in Japan. Each center is focusing on a specific area, such as cancer, cardiovascular disease. Our center is National Center for Geriatrics and Gerontology, focusing on geriatrics and gerontology, as you can see here, and was established in 2004. And this is the youngest national center among the 6 national centers in Japan. Compared to other national centers, our center is focusing on medical care and long-term care, which is a unique characteristics of our center. The mission of our center is to promote the physical and mental independence of older people. And the main targets of our research are dementia and aging. For these 2 targets, we have centers for basic science, epidemiology, genomics, technology, along with clinical science. In basic science, the Gerontology Center is specific for aging research, whereas the Center for Development of Advanced Medicine for Dementia is specific for dementia research. Each center is working hard by itself, but at the same time, I encourage collaboration between 2 or more centers, especially with our hospital, because we have a fair amount of patient data in our hospital. Okay, this slide shows the aging tsunami in Japan. In 1950, the proportion of older people was just 4.9%, but the year of 2020, the proportion of older people reached 28.7%. In addition, the proportion of older people 75 years or over is almost 15%. This trend will continue in the next 20 to 30 years, and 20 years later, Japan will be a country where 40% of the population will be 65 years or over, and almost 25% of the people will be 75 years or over. Furthermore, the number for older people over 85 years old will be 10 million in 2040 among the population of 100 million people, indicating almost 10% of the population will be 85 years old or over. In Japan, to deal with the increasing number of disabled older people, we implemented the long-term care insurance system in 2000 to support those older people in society. In the beginning, almost 2.5 million people were certified for long-term care service needs by the government. However, after the rapid increase in the number, the government started the disability prevention program by screening all older adults without certification of the long-term care service needs and tried to provide preventive services for frail older people in 2006. But the number is still increasing and reached almost 7 million at present, which is expected to make a further increase in the future and is related to the long-term care cost in society. This slide shows the top 5 causes of disability or the certification of long-term care service needs. When we started the long-term care insurance system, stroke was the top cause of disability. However, the cause of disability has dramatically changed, as you can see here. Currently, the top cause of disability is dementia, followed by stroke, senile weakness, falls and fracture, and joint disorder. The 3rd to 5th causes of disability are related to frailty. In addition, frailty is a risk for dementia and stroke. Therefore, frailty prevention is key to reducing the number of disabled older people. Today I'm going to talk about how to prevent frailty and that is very important for the promotion of healthy and active aging. And as I mentioned, I'm going to also talk about dementia prevention as well. Frailty is a clinical condition characterized by the individual's increased vulnerability to endogenous and exogenous stressors. The question is there a way to identify the subset of older adults at high risk of the adverse health outcomes clinically associated with frailty and distinguish frailty from usual aging? That's a big challenge. There are 4 key factors of frailty: sarcopenia, lower resting metabolic rate, lower energy expenditure, and chronic undernutrition. These factors are interconnected and amplifying the process, and it's hard to distinguish the first factor that started it. In the peripheral area are represented the contributor to these factors. The main contributor to sarcopenia are weight loss through protein and micronutrient deficit and increased catabolism, musculoskeletal senescence, and various kinds of chronic diseases. Sarcopenia itself, through the reduction of muscle strength and power, provoke one of the key features of the frailty assessment. Reduced walking speed is associated with lower physical activity and subsequently lower energy expenditure. In some cases, the marked reduced walking capacity can confer a disability with loss of independence and need for assistance. Neuroendocrine dysregulation, frequently observed in older people, can reduce the appetite, which is kind of anorexia of aging, and contribute to chronic undernutrition along with lower energy expenditure with subsequent weight loss. A mild and chronic inflammation can have a negative impact on these processes. So here are the key messages of frailty. Frailty is associated with adverse health outcomes and increased healthcare cost. Risk factors for frailties derive from a wide range of social demographic, clinical, lifestyle-related, and biological factors. By considering the degree of frailty in clinical practice, we can provide more patient-centered care and avoid harm. A life course approach is required for the development of public health strategies for frailty prevention. Longitudinal research on frailty is a high priority for frailty research as well as randomized control trial. As you know, frailty is associated with adverse health outcomes such as disability and death, cardiovascular disease, including diabetes, metabolic syndrome, falls and fractures, polypharmacy, ER visit and nursing home placement, dementia, and more complications after surgery. Here you can see many risk factors for frailty consisting of demographic and social factors, clinical factors, lifestyle factors, and biological factors. Demographic and social factors include advanced age, female sex, ethnic minority, low education, low socioeconomic position, living alone, and loneliness. Clinical factors include multimorbidity and chronic diseases, obesity, malnutrition, impaired cognition, depressive symptoms, and polypharmacy. Lifestyle factors contain physical inactivity, low protein intake, smoking, and increased alcohol intake. Biological factors include inflammation, endocrine factors, and micronutrient deficits, such as vitamin D. So, frailty assessment is very challenging, and generally speaking, these domains needed to be included for frailty assessment. These indicators are proposed in response to those risk factors which was presented in the previous slide. So, frailty domains should contain nutritional status, physical activity, mobility, energy, strength, mood, cognition, and social support. However, there is no single gold standard for frailty assessment, and actually the phenotype model is used to identify person for intervention and is more frequently used in clinical practice and for research purposes. The Kihon checklist, which was developed in Japan, is very useful to specify the target of intervention. This checklist is related to comprehensive geriatric assessment. The Frailty Index, which was developed by Ken Rockwood, is useful for big data analysis in a retrospective study design as well as prospective study design. Frailty screening is recommended for most of the older patients. And these are the list of frailty screening, such as frail scale, Gilbert Frailty Index, and so forth. And for the detailed screening, ELSA Dent proposed feed phenotype model, Groningen Frailty Indicator, and Frailty Trait Scale. And as you know, this is the phenotype model, which was developed by Linda Fried in the States. And according to Linda, frailty, especially physical frailty, is operationally defined as a clinical syndrome in which 3 or more of the following are present. The first is unintentional weight loss, more than 10 pounds per year, self-reported exhaustion, weakness, slow walking speed, and low physical activity. And actually, this is the Japanese version of the phenotype model, cardiovascular health study criteria. For shrinking, we use body weight loss of more than 2 kilos in the last 6 months instead of 10 pounds in the last 1 year. For weakness and slowness, we use the cutoff of grip strength and usual gait speed for Asian working group or for sarcopenia. For exhaustion, we use this question in the Kihon checklist, which I mentioned before. In the last 2 weeks, have you felt tired without reason? If participants answer yes, they are considered having tiredness. For low physical activity, we ask 2 questions, and if participants answer no to both of these questions, they are considered having low physical activity. And again, if a person satisfies 3 or more, a person is classified as frail. If a person satisfies 1 or 2, that person is classified as pre-frail. But the phenotype model assesses only physical domain. Frailty, as I mentioned, has other features such as psychological and social domain. So it would be ideal to make a comprehensive assessment in an easy way. And actually, as I mentioned, the Japanese government came up with the Kihon checklist in 2005 and tried to screen all the people without disability in the community for frailty. The Kihon checklist consists of 25 yes or no questions, which are divided into 7 domains, such as ADL, motor ability, nutrition, oral function, isolation, memory, and mood. This is a comprehensive assessment tool for frailty, adopting the idea of CGA, Comprehensive Geriatric Assessment. We also can identify the target of intervention based on the score of each domain. Actually, Satake and colleagues of our center conducted the longitudinal cohort study by dividing the cohort into 3 groups based on the Kihon checklist scores. The first group has a score of 0 to 3, the second 4 to 7, and the third 8 or over. And they were followed up for 3 years. And as you can see in this slide, older adult with 8 or over showed higher incidence of disability and death than the other groups, indicating that these people are frail and the cutoff of 8 can be used to identify frail older adults. How about the prevention and intervention of frailty? For the prevention and intervention, we, ELSA and us, published this paper in 2017. In this paper, actually this is the clinical practice guideline for the management of frailty. We strongly recommend that person with frailty be referred to a progressive, individualized physical activity program which contains a resistance training component. For the conditional recommendation, we conditionally recommend that frail person who have an intentional weight loss should be screened for reversal causes and considered for protein and caloric supplementation and food fortification. We also conditionally recommend that vitamin D can be prescribed for persons who are deficient in vitamin D. We also published the guideline for physical frailty. This is the ICFSR, International Clinical Practice Guideline for Identification and the Management of Frailty. Again, in this guideline, we recommend frailty screening for older people, and frail assessment should be followed after appropriate screening if a person is pre-frail or frail, and we need to develop a comprehensive management plan based on the screening and assessment. In terms of intervention, once again, physical activity is very important, especially resistance training is important. And as you can see here, multi-component physical activity program should be provided for frail older person. And health practitioners are strongly encouraged to refer older people with frailty to physical activity program with a progressive resistance training component. In terms of nutrition and oral health, we basically recommend sufficient or appropriate energy supplementation along with appropriate protein and vitamin D supplementation. How about the prevention in the community? The exercise class was supervised in this community. The exercise class was supervised by a physical therapist or physical trainer. I think many communities has this kind of exercise program for older people. The exercise session in this study, exercise sessions are done according to a standardized format consisting of 10 minutes of moderate intensity aerobic exercise, 20 minutes of progressive strength training, 20 minutes of flexibility and balance exercise, and 10 minutes of cool down activity. So we actually use this program for outcome measures. This is the study to address the effect of this kind of exercise class in the community. We actually invited almost 300 older people with pre-frailty and provided this kind of exercise class for 6 months. We used the control group from the community by propensity score matching. And basically we followed them up for 2 years. And actually this is the data after 1 year intervention. And we used the Kihon checklist as an outcome. So higher checklist score indicate higher frailty. So in the control group, there was an increase of Kihon checklist score in 1 year. However, in the intervention group, there was no significant increase of Kihon checklist score after 1 year. There was a statistical significant difference between control and intervention groups for Kihon checklist points. After 2 years, we checked whether these participants have received long-term care insurance service requirement, and we found 8% of older people got service requirement. However, 18% of the participants have received a long-term care service requirement in 2-year follow-up period, and risk reduction by the intervention was more than 50% in this study. So this kind of exercise class, regular exercise class and group exercise class are consisting of aerobic, balance, and resistant exercise component is beneficial for frailty prevention. Many older adults are participating for this kind of self-management group in some city in Japan. And in this class, we did not provide a physiotherapist or exercise educator. This person is responsible for group exercise, but she is a volunteer, not a healthcare professional. And basically, these people maintain this activity by themselves. In this study, the participant received 60 minutes of group training session once or twice every 2 weeks. And the exercise class was supervised by a volunteer, and before the intervention, the volunteer staff members were invited to the local government office, where physiotherapist and public health nurse provide instructions about the evidence supporting the benefit of exercise, how to do exercise, and the management of health risk. In addition, the volunteer staff received follow-up lectures about any updated information on exercise and risk management from a physiotherapist and public health nurse once every year. And we also followed the group in the self-management group and also control group selected by propensity score matching. And actually we followed them up for 2 years. And we also used the Kihon checklist for this study, and the baseline Kihon checklist score was comparable between the groups. However, during 2-year intervention, the Kihon checklist was improved in the self-management group. In contrast, the Kihon checklist score was increased in the control group, indicating this kind of self-management group activity is beneficial for frailty prevention. So in this, we continued another 2-year follow-up and found that this kind of community-based self-management activity effectively reduced new long-term care service requirement during the 4-year follow-up in community dwelling older adult. And these results suggest that the usefulness of self-management group activity to reduce the disability incidence in older people. So frailty prevention in the community can be likened to a situation where an older person drives a 4-wheel drive. The 4-wheel represent a healthy diet, exercise habit, social participation, and oral health care. The role of family and healthcare professionals is to maintain the car, and the role of the government and researchers is to maintain the road to mitigate the risk for healthy aging. In modern societies, ICT can be used to mitigate the risk as well. So the question is, how can we can apply the evidence to frailty management in our daily practice, clinical practice. I have already mentioned high prevalence of frailty and its association with adverse health outcomes, along with the impact of frailty on well-being of older people. By considering the patient degree of frailty, physician can deliver more patient-centered care, which can lead to better outcomes and avoidance of harm in primary, secondary, and tertiary prevention of disease. So primary care physicians need to understand frailty is associated with diabetes, cardiovascular disease, osteoporosis, COPD, CKD, etc., etc. And for the management of chronic diseases which I mentioned, frailty prevention and intervention should be taken into account. This is very important for healthy aging. So So to summarize, the countermeasures for frailty, exercise, nutrition, intervention are the key. And of course, we need chronic disease management as a physician, and we need to encourage social participation, and oral care is very important, and medical dental collaboration is also a key. And as a physician or geriatrician, we need to deal with polypharmacies. And we need to invite many healthcare professionals for the multidisciplinary for the approach for frailty. So multidisciplinary approach is a key for frailty intervention, like doctors, nurses, pharmacists, physical therapists, dietitian, dentist, soaring therapist, dental hygienist, and care manager for ADL decline, clinical psychologist for psychological problems, and social worker and mental health social worker for social problems. So we need to, provide this kind of multidisciplinary care for one single person, and also we need to collaborate among these healthcare professionals. Next, I'd like to talk a bit about dementia. As you know, there are two tracks basically in terms of physical frailty, from robust, pre-frail, and frail, and then leading to disability. The other track will be normal cognition, preclinical, and MCI, and leading to dementia. But as you can imagine, there are a lot of interaction between frailty and cognitive decline tracks. So the key to healthy aging, including frailty prevention and dementia prevention, will be multi-modal interventions consisting of physiocognitive training, social participation, chronic disease management, nutritional intervention, and several preventive services, as I mentioned in the frailty countermeasures. Multi-domain interventions are becoming a standard approach for dementia prevention because almost 40% of risk factors for dementia are modifiable. As shown here in the slide, ApoE4, less education, hearing loss, hypertension, and obesity in midlife, smoking, depression, physical inactivity, social isolation, and diabetes in later life are significant risk factor for dementia. Exercise is a key component for dementia prevention, and this is related to increased brain cognitive reserve and reduced brain damage, such as due to oxidative stress, and reduced brain inflammation. So for the prevention of dementia, exercise are key, as well as frailty prevention. Exercise causes changes in the brain at the anatomic, cellular, molecular level by inducing a cascade of cellular and molecular processes that promote different physiological phenomena, including angiogenesis, neurogenesis, synaptogenesis, and stimulation of neurotrophic factors that enhance learning, memory, and brain plasticity. For the anti-dementia measures, we came up with a multi-component group exercise program, which included muscle strength, aerobic exercise, and learning tasks during exercise. As you can see here, participants were asked to step exactly on each box according to pre-planned forms. And this Countermeasures has been shown to be more effective than regular exercise program. And this slide shows the comparison of brain blood flow measured by NIR. This is the image after usual exercise, and after Countermeasures, which is a dual task exercise, you can see an increased brain blood flow in this study. And actually, multimodal intervention were spreading toward globally, and this project, Worldwide Fingers Network, is led by Professor Mia Gitterveld in Sweden. she used to be in Finland. And from Japan, we participated at JMINT. This is a multimodal intervention trial for dementia. As you know, FINGER is the first successful multi-domain intervention study for dementia prevention. This is the 2-year multi-domain intervention study consisting of diet, exercise, cognitive training, and vascular risk monitoring. And in this study, as you can see here, they found a significant improvement by multi-domain intervention compared to the control group. In Japan, I'm the principal investigator of the Japan Multimodal Intervention Trial for Prevention of Dementia, which we call JMINT. This is the outline of the JMINT study. This is the multi-center open-label RCT. The inclusion criteria is all the people from 65 to 85 with mild cognitive impairment. Exclusion criteria is dementia-dependent older people and MMEC less than 24. The primary outcome measure was change in composite score of cognitive test, as you can see here. The aims of our study was to clarify the effectiveness of multi-domain dementia prevention program in Japan or Japanese older people, and to clarify the mechanisms of cognitive impairment and deterioration by using advanced technology such as serum biomarkers, omics analysis, and brain imaging. And the last aim was to make an evidence-based applicable program to future social implementation. This is the study flow. We recruited 531 participants, randomized into intervention and control groups. And control groups only received management of vascular risk factors and received health-related information every 2 months. For the intervention group, in addition to management of vascular risk factors, we provided group-based physical exercise program, 90 minutes per week. And also we provided nutritional counseling and cognitive training, as you can see here. And the intervention period was 1.5 years. This is a summary of multi-domain, multimodal intervention and the role of private companies. And medical check will be conducted at the time of regular medical examination. And Konami Sports will provide exercise class and multi-component exercise program once a week, 90 minutes for each. Sompo, health support, will conduct nutritional counseling by the meeting and telephone interviews for 15 times in total. Positive Science will provide cognitive training game by using iPad named Brain HQ in 3 separate rounds. In each round, subjects will be encouraged to do this game for 30 minutes a day and 4 times a week for 3 months each. This slide shows the special features of the JMINT study. As scientific insight, we will conduct a sensitive evaluation of cognitive and neural dysfunction. Moreover, to clarify the mechanism of cognitive improvement and deterioration, new serum biomarkers including A-beta and brain imaging analysis will be carried out. Finally, we'll obtain detailed information about the risk factor of dementia as well as omics and genetic information. With this information, we'll try to make a polygenic risk score for dementia. Based on the evidence from the JMINT study, collaborative research with private enterprises will lead to the creation of new services for dementia prevention. For example, enlightenment of dementia prevention, application for assessment of dementia risk score, monitoring and support tool for lifestyle improvement, insurance of dementia, and so forth. Lastly, these are the challenges for social implementation. The first one, the development of tailored intervention program based on the cognitive and physical function of each participant. Monitoring and management of chronic diseases is necessary. Second, relationship between the participant and staff is important for adherence, so coaching might be needed. 3, trained instructor who can provide a multi-domain intervention program to older people with cognitive impairment are needed. So we need some kind of education program. Fourth, with careful support, ICT-based program could be effective for older adults. Fifth, we need to this kind of program should be financially independent. These are the members involved in the Jamin study. So this is the last slide. In my talk, I focused on frailty and also dementia prevention. So in aging society, frailty and cognitive impairment are becoming big issues that need to be addressed. Frailty screening assessment and early intervention for frailty are required for healthy aging. Multimodal intervention for frailty and dementia are becoming a standard approach. Social implementation of anti-dementia measures and also anti-frailty measures, along with appropriate screening program, is essential. Thank you very much for your kind attention.
Thank you very much, Professor Arai. It's very nice to see you here. Welcome to our session.
Hi, good morning. Thank you.
I think we already have a few questions here. You gave a very nice overview, not only from the whole topic of frailty, but also specifically of the interventions you are applying over there in Japan and also with the international collaborations. We have the first question here. The first question is from Dr. Casa. It starts with a general comment about the different approaches and different perspectives of frailty from the physical, psychological, and social. And the question specifically is, to date, there are several instruments to screen frailty. Which instrument is more appropriate to assess and screen community-dwelling older people?
Thank you for your question. That's a very important question, and there are several screening tools for frailty screening in the community. Actually, in Japan, we are using, as I mentioned, Kihon checklist, consisting of 25 questions, yes or no question, which is very easy to be applied. And also, we have a further simplified version of simple frailty index scale, consisting of 5 questions. I didn't mention it in this talk, but just body weight loss, similar to phenotype model. The first one is body weight loss, second one is walking speed, and third one is cognitive function impairment, self-assessment of cognitive impairment, and I think the fourth is social participation. And the last one is, I forgot. Anyways, only 5 screening tools. And basically, we are using either of those tools. One is 5 questions and all 25 questions in the community, at least in Japan. I'm not sure about in other countries, but there's so many frailty assessment tools. So depending on your situation in your community, I think you can choose one of the best screening tool for frailties in the community.
Thank you. There's another question from Blanca Restrepo. In addition to frailty prevention, I think you mentioned something about it in your talk. In addition to frailty prevention, do the exercise interventions also have an impact on cognitive function and dementia?
Yes. As I mentioned in my talk, exercise is a core component of dementia prevention. And in addition to aerobic exercise, we came up with Countermeasures, which is the Geriatrics exercise. So like counting during aerobic exercise, or doing a little bit complicated movement during exercise. So this kind of complicated exercise is more important for cognitive prevention, but it's difficult to keep such kind of exercise by themselves. So we need some trainer to teach a complicated exercise program. But generally speaking, the combination of aerobic, resistance, balance training, and also it's better to have a group-based training. Is much better for dementia prevention and as also frailty and sarcopenia prevention.
Thank you. There is another question from Benjamin Seligman. I don't see oral health come up often in the United States context as a major component of frailty. Could you elaborate on why oral health should be a pillar of frailty management?
Yes, oral management is very important, at least in Japan. We have a concept of oral frailty, and then we have a screening tool for oral frailty, and then we have also a diagnosis of oral hypofunction, which is we can reimburse based on the assessment of oral hypofunction, and we have some tool like to measure tongue pressure, diadokinesis and swallowing function. So we can screen all the people with very simple. I didn't mention this in my talk, but a very simple tool for the screening of oral frailty. And then, if a patient or older person have the risk for oral frailty, we can consult dentist to further assessment. And we have a very comprehensive management method for oral frailty. That kind of information can be available in our center's homepage.
Excellent, thank you. Another attendee asked, how do you sustain the changes made to lifestyle, and what barriers are there to exercise? How do you manage this in the long term?
That's a big challenge for everybody, I guess. I don't have any good answer to the question. So as I mentioned, group-based. So peer support is very important because it's very difficult to sustain or keep exercise by themselves. So we need to create an environment where some people or several other people can get together and I think there's some kind of instruction is needed. So sometimes volunteers, sometimes healthcare professionals. So that kind of person is a key to contain that kind of group activity. So it's very difficult. Although I showed the self-management class group exercise, but it's very difficult unless local government can support those kind of activity very, aggressively.
Thank you. Saori Harada asks, regarding body weight, weight loss is one of the criteria of frailty and sarcopenia. However, at the same time, obesity is another risk factor given its underlying chronic inflammation and accompanied multimorbidity. In terms of frailty prevention, are there any specific guidelines for clinicians and or the general public to address this weight paradox effectively?
Thank you. Basically for frailty and sarcopenia, body weight loss is one of the criteria. But as already mentioned, obesity is one of the risk factors for frailty and sarcopenia as well. So generally speaking, obesity is not included in the criteria of frailty or sarcopenia except sarcopenic obesity. So that's a very good question, but I don't know how. I don't have any good answer. There's as Saori mentioned, there's obesity paradox. So generally speaking, a BMI of between 25 to 30 can be acceptable, unless a patient or other person has a knee back problem. So in that case, we can carefully reduce body weight to reduce the burden on the knee. But otherwise, we can keep the body weight, and we should focus on frailty prevention in obese patient. But if body weight is over 30, that's a problem. So we need to collaborate with dietitian and physical therapist to reduce the body weight carefully to avoid the progression of sarcopenia. But that's very challenging. So that's in an Asian context. I'm not so sure about European or American context. So that the answer can be also, only applied to Japanese or East Asian context, I'm afraid.
Thank you. Diego Arauna start with thanking you for the presentation and greetings from Chile, Latin America. From your experience, could the prevention of polypharmacy be an effective measure to reduce frailty?
I think so. Although the evidence is still lacking, we are so as a geriatrician, polypharmacy countermeasure is very important for frailty prevention and sarcopenia prevention, also dementia prevention. Especially, we need to reduce the number of PIM, potentially inappropriate medication, mainly cholinergic drug, anticholinergic drug. And that include hypnotics and other some medication for overactive bladder. And so there are so many, drugs with anticholinergic activity. So we should be very careful to use or continuously use those kind of drugs in the long term. So we should always think about the benefit of those drugs if we need to use anticholinergic drugs.
Thank you. Ayele Kaza, thank you so much, Dr. Hidenori. That's a thank you message. Karen Nichols, how are you communicating the message of frailty to the general public in Japan? My experience has been the public doesn't understand frailty or the impacts on aging well.
Yes, thank you. That's a very important question. And we, so in Japan, we have advocated the concept of frailty very frequently using some media, newspaper, TV, and also some magazine and to the public. And also we have a day of frailty that will be February 1st. So February 1st of the day of frailty to advertise the importance of frailty to the public. So we have several kind of forum for the citizens to stress the importance of frailty and also frailty prevention. And in Japan, the government said it's a time for 100 years of life. So to obtain 100 years of healthy life expectancy, frailty prevention is the key. So, collaboration with the Japanese government, we have several projects to advertise the importance of frailty to the public. Thank you.
Excellent, thank you. Abdul Sayuki, sorry for the pronunciation. We see some new research on inflammatory biomarkers of frailty. Does assessment of these biomarkers using the evaluation community-based prevention of frailty, or are these biomarkers used in community?
Thank you. At the moment, the answer is no, because we don't have a good biomarker of frailty, although we have several candidates for frailty, for the other biomarker of frailty, but we need some more time to use those biomarkers to be used for the frailty screening in the community. So maybe, takes time, but in the future it might be possible, but at the moment the answer is no.
Thank you. Dr. Nicola Toma asks, in relation to group exercises, given that economically developed societies have declined from a social adhesion perspective, is there anything or anyone thinking on exercise while engaging with young children, like daycares with day centers fused in some sort of program, helping the community this way? In the past, grandparents wouldn't be so passive and sedentary.
Yes, agree. I agree with Nicola. So we're trying to promote multi-generational, activity from grandfather, grandparents, parents and children. Nothing. Of course, it's not restricted to the family, but It's just those kind of multi-generational activity is important, but still not so common in Japan. So we need to promote those kind of multi-generational activity for frailty prevention and also dementia prevention. That's basically very good for healthy aging. Those kind of activities should be very good for healthy aging. So thank you.
Thank you. And we have the final question sorry. So we have two final questions now. We'll go very quickly. We'll go first with Muna Bukam. Thank you for this excellent presentation. My question is about the interaction between the majority of frailty risk factors, and physical activity and diet seems to be the most effective on frailty components and associated factors.
Sure. Our exercise program and physical activity, along with nutrition interventions, are the core component of frailty prevention and also sarcopenia prevention. And that should be also effective for dementia prevention. So that nobody will deny the importance of diet and physical activity or exercise intervention for frailty. But the important issue is, it's hard to apply to every single frail older person, and it's very difficult to get sustainable intervention or prevention for frailty. That's our challenge.
The final question, Hidenori, is from Diego Arauna again. Has the Japanese government implemented frailty screening in hospital services? Because in Latin America, it's an emerging issue, and this screening is not included in any care model.
Right. This is also important issue, and I don't think we have no incentive for frailty screening in hospital. So that's why we came up with 5 simple questions for frailty screening, which can be applied to all outpatient clinic. So although we strongly recommend frailty screening, but there's no incentive whatsoever at the moment. So only geriatrician and some physician apply those questions for outpatients. So that's our challenge. Thank you.
Okay. Thank you very much, Hidenori. It's always a pleasure listening to you and catching up with you. And thank you for taking the time to give this fantastic presentation and to answer our questions.
Thank you.
Thank you.
With
this, we close our session. Just a reminder about the new schedule for our Global Frailty network webinars. Please don't forget that our next one is on September 13th by Dr. Jeremy Walston from Johns Hopkins University, who is going to talk about resilience in frailty. We have a fantastic set of speakers for the next season. So please keep in touch and visit our website, listen to watch our videos, and also send us your recommendations and suggestions about topics of interest within the field of frailty. With this, I thank everyone for attending the session and wish you a very nice afternoon, morning, or wherever you are in the world. Bye-bye.
The Frailty Seminar Series 2023 to 2024.